Welcome to the session of novel oral SERDs and combinations in ER-positive, HER2-negative metastatic breast cancer, interpreting the evidence and implications for real-world practice. Now, this is part 2 of a 3-part series of virtual workshops titled Changing the Scenery in ER-positive, HER2-negative metastatic breast cancer with New Oral SERDs and Combinations, Foundations, Evidence, and Practicalities. So I am Komal Jhaveri. I am a breast medical oncologist at Memorial Sloan Kettering Cancer Center, and I'll serve as the series chair and the show host for today. And joining me is a friend and colleague, an expert speaker, Professor Giuseppe Curigliano, who's a full professor of medical oncology at the Department of Oncology and Hemato-Oncology in University of Milano, and director of the Early Drug Development for Innovative Therapies. Welcome, Giuseppe, to the session.
Thanks for the invitation.
And welcome to all of you. Thank you for participating in our workshop today. Thank you to PeerView and MetaViver for providing this educational session. And thanks to Lily for providing this educational grant for this session. Now, do engage with us today. Look out for the polling questions throughout this workshop and submit your questions to us in the chat window, and we will answer them throughout the workshop. Now, MetaViver is really our partner for this program. And what is MetaViver? It's a patient advocacy partner in this program. And it really is an organization that is focused exclusively on stage 4 metastatic breast cancer with a mission to improve the lives of people living with advanced breast cancer by funding research, advancing policies through advocacy, and facilitating a community of peer-to-peer support. So we're very grateful for MetaViver for contributing insights from patients and their care partners as a part of this program. Please do also access and use the supplemental resource compendium that is made available by MetaViver as a component of this program. You can also visit us at peerview.com, SERD25, and you can view the slides and the practice aids now and also download them after the event. For any additional information, do send us an email at live@peerview.com and join the conversation on X at Peerview. We have 2 important goals for today's discussion. First, we want to equip ourselves with knowledge about the efficacy and safety of oral SERDs and other novel ER-targeting therapies and rational combinations in ER-positive, HER2-negative metastatic breast cancer. And second, we want to enhance our understanding of the clinical and practical implications of the recent studies assessing new and emerging ER-targeted therapies in ER-positive metastatic breast cancer. Starting with innovations in ER-targeting therapy for ER-positive, HER2-negative metastatic breast cancer, talking about oral SERDs, combinations, and beyond. And Dr. Curigliano will now walk us through some of the early trials with these agents and what have they shown us thus far. So, Dr. Curigliano, up to you.
Thank you, Komal, for your kind introduction. Yes, you are right. We have new oral SERD under development. And if we have just to summarize all the data available, we can start from AMIRA-3 and Accelera trial. The first one with amsenestrant that failed to demonstrate a median progression-free survival benefit at data readout, despite there was a trend for positivity in ESR1 mutant. Similar data for giredestrant in the Accelerate trial, negative readout for median progression-free survival, but trend for positivity in ESR1 mutant. The only oral SERD today approved is elacestrant, based on the data of the Emerald trial. Elacestrant demonstrated a clinically significant and statistically significant improvement in median progression-free survival in both overall population and specifically in ESR1 mutant, and actually is approved only for ESR1 mutant ER-positive metastatic breast cancer. The SERENA-2 is another trial in which 2 different doses of camizestrant have been tested, and there was a clear benefit in terms of median progression-free survival. Just to summarize the data, as you can see here, in the Accelera trial, there was a trend for positivity in ESR1 mutant, similar data in the AMIRA trial, even if not statistically significant. Clear benefit in the Emerald trial, where elacestrant, when compared to standard of care endocrine therapy, improved median progression-free survival in ESR1 mutant metastatic breast cancer.
Based on these trials, I think what has become very clear is that certainly with monotherapy post CDK4/6, we are seeing benefit, particularly in ESR1 mutant tumors. It's not that we're not seeing benefit in ESR1 wild type, but we've not been able to show statistical significance. So that's one thing. Positive or negative study, benefit is seen in ESR1 mutants as monotherapy. But a very important realization is also that 40% across the board will still develop early progression on monotherapy, and 60% still have less than 6 months of benefit. So, do you think we need rational combination approaches to expand those benefits? And on that end, do we have any data that you can walk us through?
Yes, you are absolutely right. I believe in the ideal world, we should combine an oral SERD with CDK4/6 inhibitors because we have the rationale to combine an oral SERD with other agents. I would like to summarize the data of the EMBER-3. This was a prospective randomized trial in which patients pre and post menopausal HR positive HER2 negative who received prior adjuvant therapy with a recurrence within 12 months of completion of AI plus CDK4/6 inhibitors or progressed to a first-line AI plus CDK4/6 inhibitors have been randomized to receive imlunestrant alone, standard of care, including fulvestrant or exemestane, and then finally the arm C was imlunestrant plus abemaciclib. The primary endpoint of the study was to compare A versus B, like in the Emerald trial, A versus B in all patients and ESR1 mutant, and finally A versus C. 42% of the patients in the imlunestrant arm were mutant for ESR1. 39% of them had also a PI3 kinase mutation. The most recent endocrine therapy was in 63% of the patients, a treatment for advanced breast cancer. And when evaluating previous CDK4/6 inhibitors, we have palbo in 61% of the patients, ribociclib in 29%, and abemaciclib in 10%. So usually the characteristics were very well balanced, including in patients with ESR1 mutation. If we look at the data, imlunestrant showed reduced risk of progression or death compared with the standard of care in patients with ESR1 mutation. So imlunestrant led to a 38% reduction in the risk of progression or death in patients with ESR1 mutation. The other primary endpoint was to evaluate median PFS in the intent to treat population. And as here reported that there is absolutely no difference, median progression-free survival was 5.6 months in the imlunestrant arm, 5.5 in the standard of care. So the majority subgroup of patients without ESR1 mutation showed no difference in median progression-free survival. The next question was whether we can combine imlunestrant plus abemaciclib, and when comparing arm A, imlunestrant alone, versus arm C, imlunestrant plus abemaciclib, median progression-free survival was improved from 5.5 months to 9.4 months. So the combination of imlunestrant and abemaciclib led to a 43% reduction in the risk of progression or death over imlunestrant alone. What is really interesting, when evaluating in a subgroup analysis the benefit of the combination in ESR1 mutant or in ESR1 wild type, there is exactly the same benefit. This is a very important information because if the combination will be approved, we don't need to test. We can prescribe directly the combination of imlunestrant plus abemaciclib, avoiding the stress also of ESR1 mutation detection. In another subgroup analysis, imlunestrant plus abemaciclib was investigated in the patient population who received prior CDK4/6 inhibitors, so with the PI3 kinase mutation. Also, in these two subgroups, there is a consistent benefit of imlunestrant plus abemaciclib in both the population who received previous CDK4/6 inhibitors and in the population with PI3 kinase mutation. Evaluating, of course, all the subgroups, there is a consistent benefit of the combination of imlunestrant plus abemaciclib, independently of previous CDK4/6 inhibitors, ESR1 mutational status, PI3 kinase mutation, or concurrent mutation of PIK3CA and ESR1. And here, in this beautiful slide, you can see all the subgroup analysis according to ESR1 mutation, overall population, and of course also second-line previous CDK4/6 inhibitors and other parameters. What's about safety? This is really important. Imlunestrant was very well tolerated. Let's say that incidence of grade 3 or more toxicity was reported only in 17% of the patients. Diarrhea grade 3 in less than 1%, mainly related, of course, to the use of imlunestrant alone and other oral SERD. In the combination arm, imlunestrant plus abemaciclib, diarrhea grade 3 or more was reported in 8% of the patients. Of course, the safety was more consistent with the known abemaciclib profile rather than imlunestrant. During ASCO, we presented the data of patient-reported outcome, and we evaluated global health status and quality of life and functional domains across the subgroup of the EMBER-3 trial, and consistently with the primary results of EMBER-3, the patient-reported outcome results reinforce the benefit of imlunestrant as a monotherapy or combined with abemaciclib as an all-oral targeted therapy. I would like to mention only the data of time to deterioration analysis, in which usually there was a numerically better outcome for patients who received imlunestrant versus standard of care, much more better in the combination imlunestrant plus abemaciclib. And another important point was the importance of injection site reaction, that for the majority of the patients was a major concern. So having an all-oral combination is a unique opportunity for patients with HR-positive, HER2-negative metastatic breast cancer.
That's such fantastic a way of ending that on that note. And thank you for walking us through this comprehensive data set from the phase 3 EMBER-3 trial. So let me pause here to ask you a couple of questions that I was thinking about in with respect to this data set, and what should we be thinking about? Do you think combinations are the way to go? We already have monotherapy. How do you think we should be making our decisions, or how will you be making your decisions? Say if you had a doublet available or a combination therapy available, who would you offer monotherapy and who would you offer combination to?
Oh, this is an excellent question. So, personally, I believe that if the combination will be approved, I will propose to all patients in the second line the combination of imlunestrant plus abemaciclib. We know very well that oral SERD monotherapy can provide a very limited benefit. If you have to observe the long-term benefit is only in the patients with the longer exposure to previous CDK4/6 inhibitors for more than 1 year or more than 18 months. So personally, I believe that having the combination, I would avoid potentially the testing, and I would give imlunestrant plus abema to any patient in the second line setting. We know already that CDK4/6 inhibitors beyond progression can give a benefit to the patients. So having the opportunity in ESR1 mutant or also in the wild type, I would like to be provocative here. To give imlunestrant, I believe this can be a huge opportunity for our patients.
Thank you for sharing that. You know, one other thing I was thinking about, EMBER-3 did allow patients to get enrolled and be treated either in the first line, which represented, as you showed, in 30% of the patient population, and then the most majority of the patient population were treated in the second line. So, do you think if this combination was available, would you consider this? And when would you consider this in the first line?
No, personally, I would rely on the data of AI plus CDK4/6 inhibitors for endocrine sensitive and fulvestrant plus CDK4/6 inhibitors for the resistant. So, personally, I would not consider this regimen in the first line. I would prefer to give this type of treatment to patients in the second line setting, unless this is a comment, a personal comment in the first line, in endocrine resistant disease in a patient who underwent, let's say, an NGS, you discover that there is an ESR1 mutation. Maybe in that specific scenario, I would consider personally the combination of imlunestrant plus abemaciclib.
I completely agree with you. Yeah, I think the point you brought up is excellent about the ESR1 mutation there. That in that setting, which is not a majority, I think we've seen about 5 to 7% prevalence at baseline before first line metastatic therapy. There, I would definitely be leading and reaching out for imlunestrant abema if that was available. And maybe to your point, I'm just stretching ahead for an endocrine resistant where I was considering fulvestrant, given the data that you showed, whether you see an ESR1 mutation or not, and you're seeing the benefit, I might be okay using this all oral regimen. And I would certainly have a discussion with the patient on that for this endocrine resistant patient population. But for a sensitive patient population, I think I would certainly be only reaching out for AI CDK. The only reason I would be considering fulvestrant CDK is if the patient preference is there for various reasons, including cost or access. But otherwise, I think that for endocrine resistant, it seems like it could still be a reasonable option to think about the doublet combination in the first line, given that EMBER-3 did not allow progression on prior fulvestrant, and we really don't know what imlunestrant abema would fare after, say, fulvestrant ribo. So I think we don't necessarily have that data set, but I don't think that that's a big proportion of patients in clinic.
This is a very good comment. Personally, I was very surprised that when I saw the data on patient-reported outcome,
Yeah.
since this educational module is also for patients. So patients complain about intramuscular injection of fulvestrant. And personally, I can tell you that in ESR1 mutant, imlunestrant is superior to fulvestrant.
Right.
But in ESR1 wild type, it's not inferior. So if a patient would prefer to receive a null oral combination, we need to guarantee the access to this type of combination also in the wild type, because as I showed at ASCO, it's very clear that patients complain about intramuscular injection of fulvestrant, and quality of life of patients in this setting is a priority for me.
Fantastic. Yeah, no, I think excellent points. Let's move on. But before we move on, why don't we answer a polling question? So, moving on, I think we heard about monotherapy data from you, Giuseppe, post CDK4/6, and we saw that it's approved in ESR1 mutant tumors. We heard about the data from EMBER-3 for combinations and how that was active regardless of any mutation. What about the ctDNA adaptive approach, where you're tracking the emergence of ESR1 mutations on first line therapy, on first line AI CDK, and then switching to an oral SERD for emergence of these mutations without radiological progression? Maybe you can walk us through what did we learn from such a strategy in Serena 6?
Yes, this is an excellent question. The first study to demonstrate that interception of ESR1 mutation and switch to a SERD that in that scenario was fulvestrant can improve the median progression-free survival. And the PADA-1 almost 2 years ago clearly demonstrated what is reported in the Serena 6. The Serena 6 is exactly the same design of the PADA-1, prospective randomized trial for patients received a first-line treatment with AI plus CDK4/6 inhibitor that have been tested for ESR1 mutation every 2-3 treatment cycles And once ESR1 mutation was intercepted without radiological progression, patients have been randomized to switch to camizestrant 75 milligram versus the same treatment, so AI plus CDK4/6 inhibitors. If we check the patient characteristics of the SERENA-6, this is an important information. Almost the majority of the patients had the median exposure to AI plus CDK4/6 inhibitors for 22 months. And time from initiation of AI plus CDK4/6 inhibitor to randomization was more than 18 months for 62% of the patients and less than 60 months for 38% of the patients. Just to remind to you, almost 60% of patients tested intercepted the ESR1 mutation on the first determination. With this switching strategy of ESR1 interception without radiological progression, the SERENA-6 demonstrated a median progression-free survival benefit from 9.2 months to 16 months, and the benefit was very clear since the beginning. This is a slide that I would like to comment a little bit. Here is reported one item of the EORTC quality of life Q30, and here is demonstrated that time to deterioration and global health status quality of life was delayed by anticipation of camizestrant. Why I would like to comment on this? Because we know perfectly that aromatase inhibitors can give a lot of side effects, arthralgia, fatigue, insomnia. So I would like to know if this delay in time to deterioration is more related by the switch to camizestrant rather than to a real delay in time to deterioration. In terms of adverse events, the majority of adverse events were, of course, related to the safety profile of the CDK4/6 inhibitors, so neutropenia, anemia. In terms of photopsia, this was reported in 20% of the patients with only 1% grade 3. So photopsia is there, but finally seems not to be a major issue for our patients.
No, I think this is great, and I think it's a great effort to try and see how can we make a difference even before we see radiological progression, which is what we currently utilize in clinic when we're thinking about switching therapies. And by doing this approach of molecular progression and intervention for molecular progression, can we improve outcomes? So, do you think the data from SERENA-6 addresses that question of can molecular progression related interventions change outcomes to the point that it should become a standard of care?
The trial design, you would agree with me, is beautiful. No, it's the ideal trial design of precision medicine. You know, we are missing the crossover arm here. So I would like to see whether patients with the radiological progression at the end of the story may derive exactly the same benefit if you have a crossover arm. I believe the absence of the crossover will limit a lot, I believe, the implementation of this type of approach. So personally, I believe the data are practice changing. For sure, they will be reported in clinical practice guidelines, but between guidelines and implementation in clinical practice, I believe there will be a gap. So why? Because we don't have the data of the crossover, and this is a consideration that should be done.
Yeah, no, I think it's an excellent point because, as you pointed out, there are options available to patients at the time of progression. So, not having this crossover, but, when otherwise we should have had, patients who can get these oral SERDs at the back end and maybe even combination of oral SERDs with targeted therapy at the back end. Are we truly, based on this data set, able to confirm that we're making a big difference in outcomes? So I think I agree with you. I think it's an excellent study. I think it's an excellent futuristic view of trying to make a difference in patient outcomes that we need to adapt to and learn more about in clinic. We need to design more studies like this. And I think this study is probably setting the stage as a foundation in addition to para 1, to then raising all the important questions that we still need to continue to address before we can definitively say, yes, this is the way we need to do because this makes a difference in patient outcomes. So, completely agree with all the comments that you have made. So, thank you for that. Maybe other trials that are also ongoing, talking about these combinations. Hopefully, they will be available and maybe we'll be able to offer additional options to our patients. You want to walk us through some other designs?
Yes, I will summarize very briefly this data. Of course, the Adela trial that is exploring the combination of elacestrant plus everolimus versus elacestrant plus placebo. As you know, still in Europe, everolimus is used in patients without PI3 kinase mutation. Then we have the Pioneer trial, giredestrant plus CDK4/6 inhibitors versus fulvestrant plus CDK4/6 inhibitor, and the EVERAR trial, combining giredestrant plus everolimus versus standard of care plus everolimus. Another trial is the Persevera, giredestrant palbo and letrozole. This is a trial in the first line setting, very similar, of course, to the ones that have been already performed. And finally, camizestrant plus palbo plus anastrozole placebo. The Serena 4 will be available for sure at ESMO this year, so we will see whether an oral SERD plus CDK4/6 inhibitor is better than a standard of care. And then we have a lot of trials in the adjuvant setting, the treat ctDNA using elacestrant by ESR1 interception in the high-risk population in the adjuvant setting. And then we had the Cambria 1 and Cambria 2 that are trials in which there is a frontline use of camizestrant plus CDK4/6 inhibitors in the high-risk population and alone in the other population. And then the Glidera trial, so giredestrant for 5 years plus abemap for 2 years, and Ember 4. This is a large prospective randomized trial including thousands of patients and evaluating the role of imlunestrant in the adjuvant setting. So up to you to comment on the adjuvant trials.
Yeah, no, I think it'll be very interesting to see what strategy might be the most impactful because I think certainly the advantage to these oral SERDs is the tolerability profile. While there are differences in the safety profile, they are all predominantly low-grade toxicities. And can they overcome the toxicity issues that we face with, say, aromatase inhibitors and tamoxifen in clinic? That's one big impact. Hopefully, these trials can shed light on when they're reported out. But I think a strategy of whether it should be an upfront way of randomizing oral SERDs with these standard of care drugs versus a switch strategy after a couple of years is something that is being evaluated in Ember 4 and in Cambria 1 study. And I think it'll be interesting to see which strategy might be effective. And certainly the treat ctDNA is again focusing on can we utilize ctDNA based adaptive strategies to see if we can make a difference in early stage. So really looking forward to seeing what those readouts would look like and what strategy might be the most appropriate. I don't know if Giuseppe, you had any thoughts if one of the strategies resonated more with you or your thought process, if you want to comment on that.
But for sure, in the high-risk population, I prefer the switching strategy. If you remember, in the Big 198, the switching strategy was exactly the same that the frontline AI. And in this context, switching from an AI to an oral SERD can improve also the quality of life of patients. And in the adjuvant setting, you know better than me that quality of life is an issue because side effects of AI mainly for premenopausal patients are a nightmare, and we manage a lot of side effects of AI in the premenopausal setting, but also in the postmenopausal.
Excellent point about side effects and tolerability and adherence. We know that the adherence for standard of care AI and tamoxifen, 50% of our patients don't even finish 5 years of therapy. And so this is very, very important to improve mortality rates and to improve outcomes. And very interestingly, when we look at the phase 1 data sets for these oral SERDs, we've learned that none of them really hit the maximum tolerated dose. I think the recommended phase 2 doses were selected based on the safety, PK, and efficacy profile, so a biologically effective dose. And so we have the ability to dose reduce these drugs, which is not something we can do with aromatase inhibitors and tamoxifen, which is fixed dosing. So hopefully all of those attractive features And these strategies that are currently being studied it will make a big impact in outcomes, in adherence, and in toxicity rates. So, again, before we move on, let's answer a polling question. So, our audience can do that again to help us understand how to interpret the results of the oral SERT trials in ER positive, HER2 negative breast cancer. So, please take a moment and answer this polling question. Now, besides oral SERDs, which have certainly been really, really impactful and have been approved, and many are in phase 3 settings in various different strategies, including early stage now, there are other emerging novel endocrine therapies as well. Maybe, Giuseppe, you can talk to us a little bit of those novel endocrine strategies, their mechanisms of actions, and maybe some data sets that have recently been reported out.
So we have novel SERM like lasofoxifene or bazedoxifene. Lasofoxifene was a drug tested 10 years ago for the treatment of osteoporosis, and now this is a drug repositioning, and there is a registration trial ongoing. We have SERCA, selective estrogen receptor covalent antagonist. H3B6545 is an example. Then the PROTAC, vepdegestrant, is an example, a proteolysis targeting chimera. And then the SERAN, complete estrogen receptor antagonist like palazestrant. We have data from vepdegestrant. They have been presented at ASCO this year. The VERITAC-2 was a global phase 3 randomized trial for HR-positive, HER2-negative disease, comparing vepdegestrant to standard of care. In this case was fulvestrant, with the primary endpoint that was PFS in intent to treat population and ESR1 mutation, exactly like in the EMBER-3 and the EMERALD trial. The benefit in the primary endpoint was a marginal benefit in ESR1 mutation, absolutely no difference in the overall population. When evaluating investigator-assessed PFS, here again there was a benefit in patients with ESR1 mutation and no benefit in the overall population. Here we have a safety profile that is a little bit different respect to other drugs. We have fatigue in 27% of the patients, increase on AST and ALT in 14%. And finally, discontinuation rate was reported in 3% of the patients. I don't know whether or not there will be further development for vepdegestrant, but it's a very interesting mechanism of action.
Fantastic. So again, before we move on, please answer another polling question on monotherapy approaches with new ER-targeted therapies in ER-positive, HER2-negative metastatic breast cancer. And last but not the least, we have patient perspectives and experiences and insights from MetaViver Group. So this is really a patient video that I'd like you to watch that highlights the importance of patients' understanding of new therapy options such as oral SERDs and other ER-targeting therapies, patient-reported outcomes, and the benefits of making this information accessible to patients.
Hi, I'm Kelly Shanahan. I've been living with metastatic breast cancer for almost 12 years. I am the president and director of research of MetaViver, a nonprofit that raises money and funds metastatic-focused research. I'm thrilled to be with you today to give the patient perspective. There are so many treatment options available to your patients, and it's important that you discuss all the available options with every single one of your patients. Don't make assumptions about what someone may want based on their age or something else. We have the older therapies like aromatase inhibitors or tamoxifen, and we have the newer oral SERDs and more of those coming down the pike every day. We have the injectable SERDs. We have Protex and Serans and every other version of alphabet soup that may become available. So talk to your patients about all the options. Everybody's different. But if you have these discussions with your patients, you can help them come to an informed decision. I think it's also really important to talk to your patients about patient-reported outcomes that may not have been presented in the initial clinical trial data, because we all know that the cancer Olympians that are in the trials are different than the real-world population who will be taking the drugs. So again, give your patients all the data, work with them so that everybody is happy with the choice of endocrine therapy.
So, in summary, I think we really heard a lot of rationale for utilizing oral SERDs for ESR1 mutant tumors in the metastatic setting. We saw a lot of exciting data and the wave of the future and the rationale for combinations in this space. So, beyond CDK4/6 in the first line, utilizing novel endocrine therapy approaches, not only as monotherapy, but certainly reaching out for combinations. We await additional combination trial data sets, including agents targeting the PI3K, AKT, mTOR pathway, some of which will be reported out later this year, and we'll see how that impacts our treatment paradigm. Certainly a lot of excitement for early stage with oral SERDs to see how can we further improve outcomes in early stage as well. So please complete and submit your post-test and evaluation for credit. Download the slides and the practice aids. I'd really like to thank you all for joining us today, and thank you, Dr. Curigliano, for such an excellent discussion and providing your insights in this area.
Thank you for the invitation.